Situation in France and around the world with respect to so-called MERS-CoV, the Middle East Respiratory Syndrome, which is a coronavirus that has come to public attention in 2012. No conflict of interest. So what's our subject? MERS-CoV. MERS-CoV was isolated for the first time in June of 2012 in a patient in Saudi Arabia. It had different names. It was first called the Aaronson Medical Center coronavirus, then nCoV, and finally MERS-CoV, the Middle East Respiratory Syndrome coronavirus. So how did all of this start from the point of view of us as epidemiologists? The initial alert was triggered in Jordan in April of 2012. Jordan notified a situation of a severe respiratory syndrome of an unknown origin. That kind of notification comes in automatically to us through the CDC, our European Controlled Disease Center. The situation was quite simple. It was reported by the media in an intensive care unit in Zarqa in Jordan, where 7 nurses, a doctor, and a member of the family of a patient were infected in a clinical syndrome that was similar to pneumonia but couldn't be identified as such. Now, some unconfirmed sources spoke of other cases, and the ECDC, the European Control Center for Diseases, started its risk assessment. So to begin with, we didn't really have much to investigate, except that this cluster of cases was of concern. I mean, healthcare professionals in good health becoming infected, that was a reason for an alert. Then in September of 2012, on the 15th, in fact, that was confirmed with the notification by our British colleagues of the presence of this new coronavirus with 99.5 genetic identity with the previous one in a patient having traveled to Saudi Arabia before the illness. It was a Qatar resident who fell ill in the UK. Now, this became more specific. Specific surveillance was put in place at all national and international levels. We all remember, of course, the SARS virus, and we didn't know what this could result in because the Jordanian cluster was disquieting. So monitoring was put in place. Everybody played their proper role. The ECDC on 24 September 2012, after a first rapid risk assessment, published an evaluation of the risk. That's what the ECDC does. That's its task. And what we were waiting for most was a definition of the case. I mean, before agreeing on what we would do, we needed to have a definition of the case. So that was published, and in each of our countries, we put monitoring in place. And it was the INVS, the Institute for Healthcare Surveillance, that was responsible for that in France. Now, the rapid risk assessment was published, providing a validated methodology to all, but that methodology was made available on the 27th of September, and our National Reference Center in Pasteur was ready to act as of the 1st of September, the first week of October. So, I mean, we can speak later about the overall mechanism that is applied in such a case. But the case definition, I mean, this is the key for dealing with this kind of potential epidemic. So the definition was the possible. Any individual having traveled to the Saudi Arabian Peninsula or neighboring countries who in 14 days after return to their home presented clinical signs or radiological signs of acute respiratory distress or infection of the pulmonary parenchyma. I mean, there's something more specific there that can be discussed by a subsequent speaker, with a fever, coughing, and no other identified etiology that could explain the pathology. Now, the presentation can be atypical, in particular insofar as the digestive system is concerned. Clinicians may make a mistake in the first few days. Now, that's the case identification or case definition. Then you add to that any individual having contacted such an individual who within 14 days after such a contact has similar symptoms. The confirmation is done through a clinical identification, and that is the protocol to be followed. Now, the partners involved. When you have this kind of emergency, you really need to get organized to treat the patient, but organized collectively. The objective of this organization is to detect and limit transmission. So you need to detect the case, identify the case, get appropriate laboratories involved. In France, it's just one, it's the CNR, and you need quickly to isolate the patient, identify his or her contacts, the contacts of contacts, if the contacts have been organized. So it is quite a cumbersome organization at the national level, at the local level, going from the patient bedside down to local authorities and up to European authorities, because some individuals have contacts in an airplane. And if a plane arrives somewhere, then you need to do contact tracing with all of the passengers who have gone to other countries in Europe or elsewhere in the world and to test them for possible infection. Now, this may look a bit complicated, but each of the partners involved knows exactly what his or her role is. You have the clinical level, the declaring entity, the regional center that provides the means for a proper investigation, for proper isolation of the patient, to what department this patient should be directed. And then you have public health monitoring, trying to paint an epidemiological picture of the situation. And then you have the CIR, the Arlan, and the Cyclins. They are responsible for tracing nosocomial infections. Then you have the CNR, which is the laboratory responsible for validation of diagnosis, the learned societies. Then the Director General for Public Health will talk about the role of the DGS, and then you have the European agencies that are responsible for similar monitoring at the EU level. So how did it work in this case? It worked in this case quite well, thanks to you, the clinicians, because right from the outset of the detection system, through the learned societies, through your networks, we had notifications that came in and that in most cases were very relevant and that did raise a suspicion of this coronavirus. Here you have the two cases that were observed in France. Bernard Guéry will speak to them. One case imported from Saudi Arabia and one contact case from that imported case, and then you have all of the notifications. Now, when we receive a notification, we have several stages that we go through. A first stage is a clinical and epidemiological discussion on the basis of the information obtained. Is this a possible case? Some are rejected on the basis of our epidemiological experience or on the basis of our discussion with the clinician because the time period is not right, the person came back too late, or what have you. So you have these possible cases that are in the darker blue color. And then subsequently, they are characterized as confirmed or not. You can see how the histogram took shape over time. There were quite a few notifications after the two confirmed cases, and then we had two waves associated with the pilgrimages to Saudi Arabia, a shorter pilgrimage and then the Hajj itself. So that's why there are these three peaks. Now, we are in a position as a function of the gravity of the situation. We are in a position to deploy all the resources required for notification, for getting in touch with clinicians, for identifying cases. All of the resources required can be deployed very quickly. So that is because the epidemiologists, of course, are very interested in this kind of situation. Now, what about the current international situation? As of 10 January, there have been 1 or 2 cases since, but as of 10 January, here's the situation. 178 confirmed cases and 75 deaths. That is the visible part of the iceberg. We're aware of this, but the countries concerned are making more and more efforts to confirm these cases. Now, where are these cases located? This is important to keep in mind because that gives you a sense of whether or not we will be alerted or not. The great majority of cases were in the Arabian Peninsula or originated from the Arabian Peninsula. That went from Israel. We don't have any cases from Israel, but we do believe that neighboring countries could be affected as well. There's Jordan, Saudi Arabia itself, Qatar, the United Arab Emirates, Oman, and Kuwait. We also had cases in Tunisia, but they were imported from the Arabian Peninsula. And in Europe, we have had cases either directly imported or resulting from contracts with imported cases, in particular in the United Kingdom and in France. So the geographical distribution is very well defined. Here you have the same information in a different form. In blue, you can see the majority of cases coming from Saudi Arabia. That's the main source, and it's remaining quite stable over time. Jordan notified the first cluster with some delay, but here one has to take into consideration the notification delays, which can be quite random there. Now, so this is an epidemic that is not spreading as quickly as the SARS disease, but it can be of concern. Where do we stand insofar as our epidemiological understanding of this illness is concerned? Well, it affects first and foremost men who are older than 50 and who have comorbidities. That really is the great majority of the index population. The index cases are generally speaking a bit younger, but the typical case is a man above 50 who is immunodepressed. Lethality is high, above 40%, and higher among men, of course among older persons, and among those who are most comorbid. It's a very severe pathology. It's very serious in consequences. In 90% of cases, it results in hospitalization, and in 75% in resuscitation, often lengthy and cumbersome resuscitation. The symptoms, well, I mentioned those already. Now, transmission. This is one of the most important, interesting aspects, and there's still a lot of open questions when it comes to MERS-CoV transmission. The cluster. Let's start with the cluster. You have the confirmed cases in circles, and in dots, the probable cases. This is what was identified retrospectively once we saw this cluster of cases arising in a dialysis unit. From patient to patient in a ward that concentrates people who are immunodepressed, who have comorbidities. And then we have a few family members, a few healthcare professionals with a lower rate of transmission. However, now maybe it's worth saying a few words about the viral load. It is significant first and foremost in the lower respiratory tract, and that makes it difficult to do the diagnosis. You really have to get into a deep sample from the lower respiratory tract. If you just take samples from the pharynx, that's not enough. But the excretion can be very prolonged. The second patient in Lille who died excreted over a prolonged period. The virus is present in the blood and the urine, but there is a lot still to be learned about this virus. A few more words about transmission. One of the key parameters in epidemiology is the rate of reproduction. Is there a significant risk of an epidemic? For this coronavirus, which has not mutated, in coronavirus's mutation is a danger. We have an R0 that has been estimated by several authors, but they're below 1. So one case is likely to transmit to less than one case. Now that's reassuring. That means that it is not very probable that we move towards a situation of epidemic, provided the virus does not modify itself. That doesn't mean that the situation is less serious, because even a low transmission and reproduction rate can have a significant impact on the few contacts having been infected. Now, this is where this new coronavirus situates itself in the family of coronaviruses. Coronaviruses are viruses that are borne by bats and certain mammals. Our MERS-CoV is very close to a coronavirus to be found in bats called Pipistrellus. So we do suspect bats of having played a role in the emergence of this coronavirus. Now, there are human coronavirus that are responsible for head colds that can be a problem every year. So MERS-CoV is a coronavirus like the SARS virus. Now, on the reservoir, we have more and more knowledge about that. We have identified bats and dromedaries as natural hosts, and they have MERS-CoV virus is very similar to those of human beings. Now, we don't know much more about how this is transmitted from animal to man. The French patients, what did they do in the United Arab Emirates? What did they eat? Whom were they in contact with? One of our patients had been in touch with dromedaries, with falcons, but we were not in a position precisely to identify how he was contaminated, and that's true of many other patients in other countries. Now, it's the index cases did not transmit seriously from man to man, but the transmission from animal to man seems to be more prevalent. Now, the above hypothesis is more likely for the time being, but we cannot be certain. In epidemiological investigations, we haven't yet found caves with bats where the coronavirus is present, but we do know that they do leave excrement in various places that could pass that on. So it's a bit complicated. We're not sure about the role of bats. So, as I said, open questions remain. The asymptomatic forms, a few asymptomatic forms have been identified around the clusters, but we don't know what the number of these forms is, how prevalent they are. We haven't been able to describe them. This could play a role in the virus jumping from one place to another. But we don't know whether it's because of a human being moving from one place to another, or dromedaries, camels passing on from one to another. Risk factors, we don't know exactly what the risk factors for contamination are. The diagnostic tools need to be improved to be entirely reliable. There's a lot of clinical research that needs to be done on diagnosis and treatment. So in conclusion, the epidemic is present. We have poorly identified transmission hubs that exist in the Arabian Peninsula. The risk is quite limited, but there is a risk of transmission from man to man that justifies putting in place clinical and epidemiological surveillance and monitoring at the national level in order that emergence be identified as quickly as possible if necessary. So early warning is important, and there's a lot of research to be done. There's an enormous amount of research to be done before we fully understand this coronavirus.